everyone. Today we learn about shock, different types of shock, and then after this session we'll solve an MCQ regarding this topic. Okay, let's begin. Shock. Shock occurs when there is insufficient tissue perforation. The pathophysiology of shock is an important surgical topic and may be divided into following etiological groups: septic shock, hemorrhagic shock, neurogenic shock, cardiogenic shock, anaphylactic shock. Septic shock is a major problem, and those patients with severe sepsis have mortality rate in excess of about 40%. In those who are admitted to the intensive care, mortality ranges from the 6% with no organ failure to 65% with 4 organ failure. Sepsis is defined as an infection that triggers particular systemic inflammatory response syndrome. It is characterized by the body temperature outside 36 or 38 degrees Celsius. That is less than 36 in hypothermia and more than 38 hypothermia. Heart rate of more than 90 beats per minute. Respiratory rate of more than 20 beats per minute. WBC count of more than 12,000 or less than 4,000. Altered mental status or hyperglycemia in absence of diabetes. Patient with infections. Two or more elements of source meet the diagnostic criteria for sepsis. Those with organ failure have severe sepsis, and those with refractory hypotension. Septic shock. During the septic process, there is marked elevation of immune system with extensive cytokine release. This may be coupled with or triggered by systemic circulation of bacterial toxin. These all cause endothelial damage and neutrophil addition. The oral hallmarks are thus those of excessive inflammation, coagulation, and fibrinolytic suppression. The Surviving Sepsis campaign of 2012 highlights the following key areas for attention: the prompt administration of antibiotics to cover all likely pathogens, coupled with rigorous search for source of infection. Hemodynamic stabilization. Many patients are hypovolemic and require aggressive fluid administration. Aim for a CVP of about 8 to 12 centimeters of water and a mean arterial pressure of more than 265 mmHg. Modulation of septic response. This includes maneuver to counteract the changes and includes measures such as tight glycemic control. The routine use of steroids is not advised as it can cause steroid-induced hyperglycemia. The surgical patients. The main group of septic shock includes those of anastomotic leaks, abscesses, extensive superficial infections such as necrotizing fasciitis. When performing surgery, the aim should be to undertake the minimum necessary to restore the physiology. These patients do not fare well with prolonged surgery. Definitive surgery can be more safely undertaken when physiology is restored and collecting and restored and clotting in particular has been normalized. Coming to the hemorrhagic shock. The average adult blood volume is comprises about 7% of the body weight. That's in about 70 kg adult will equate to about 5 liters of blood, which is about 7% of the body weight. This changes to about 8 to 9% of body weight in children, and with age it slightly lowers in elderly. The below table outlines about the four major classes of the hemorrhagic shock and their associated physiological sequelae. Hemorrhagic shock can be divided in class 1, class 2, class 3 and class 4. Blood loss in ml. If blood loss is less than 70 ml, it's class 1, and if blood loss is about 750 to 1.5 ml, 1.5 liters, it is class 2, and if it is 1.5 to 2 liters, it is class 3, and if it is more than 2 liters, it is class 4. Blood loss. If blood loss is less than 15%, then it comes in class 1, and if blood loss is 15 to 30%, then it is class 2, and if it is 30 to 40%, it is class 3, and if it is more than 40%, it is class 4. Pulse rate. Pulse rate is less than 100, which is normal in class 1. But from class 2, the heart rate increases, patient experiences tachycardia. In class 2, it is more than 100. And if pulse rate is more than 120, class 3, and if more than 140, class 4. And blood pressure, it remains normal in class 1 and class 2, but it decreases from class 3. Respiratory rate in class 1, it is about 14 to 20, almost normal, like range of normal. From class 2, tachypnea develops 20 to 30 in class 2, 30 to 40 in class 3, and more than 35 cycles per, like respiratory cycles per minute from class 4. And urine output, class 1 will have more than 30, and class 2 will have 20 to 30, and class 3 will have about 5 to 15, and class 4 will have 5 mm. Slowly the urine output decreases, and symptoms in class 1 patients appears to be normal, but from class 2 patient will be anxious, and in class 3 patient will be confused, and in class 4 patient will be lethargic. Decreasing blood pressure during hemorrhagic shock can cause organ hyperperfusion and relative cardiac, that is myocardial ischemia. The cardiac index gives a numerical value for tissue oxygen delivery and is given by the equation of cardiac index is equals to cardiac output by body surface area. In patients suffering from trauma, the most likely cause of shock is hemorrhage. However, the following may also be the cause or occur concomitantly, that is tension, pneumothorax, spinal cord injury, myocardial contusion, cardiac tamponade. When assessing the trauma patient, it is worth remembering that in order to generate a palpable femoral pulse, an arterial pressure of about more than 65 mmHg is required. Once bleeding is controlled and circulatory volume is normalized, the level of transfusion should maintain a hemoglobin of about 7 to 8 in those patients with no risk factors for tissue hypoxia, and hemoglobin should be 10 for those patients who have such risk factors. Okay, coming to the neurogenic shock. This occurs most often following a spinal cord transaction, usually at higher level. There is resultant interruption of the autonomic nervous system. This results in either decreased sympathetic tone or increased parasympathetic tone, the effect of which is decreased peripheral vascular resistance mediated by marked vasodilation. So the results is decreased preload. The results in decreased preload, decreased cardiac output, according to Starling's law, and there is a decreased peripheral tissue perfusion and shock is produced. In contrast to many other types of shock, peripheral vasoconstrictors are used to return the vascular tone to normal. Cardiogenic shock. In medical patients, the main cause is ischemic heart disease. In traumatic setting, direct myocardial trauma or contusions are more likely in traumatic setting. Usually, ischemic heart disease in medical patients. Evidence of ECG changes and overall sternal fracture or contusions should raise the suspicions of a myocardial injury. Treatment is largely supportive, and transthoracic echocardiography should be used to determine the evidence of pericardial fluid or direct myocardial injury. The measurement of troponin levels in trauma patients should be undertaken, but they are less useful in delineating the extent of myocardial trauma than following the MI, that is myocardial ischemia. And when cardiac injury is of blunt nature and is associated with a cardiogenic shock, the right side of the heart is most likely the site of injury with a chamber or valve rupture. The patient requires surgery to repair these defects and will require cardiopulmonary bypass to achieve this. Some may require intra-aortic balloon pump as a bridge to surgery. We call it NCCUs, we call it IABP. And coming to anaphylactic shock, anaphylaxis may be defined as a severe life-threatening generalized or systemic hypersensitivity reaction. Anaphylaxis is one of the few times when you would not have time to look up for the dose of medication. Okay, adrenaline is far the most important drug in anaphylaxis and should be given as soon as possible. The recommended doses for adrenaline, hydrocortisone, and chlorpheniramine are as follows. These are the adrenaline, hydrocortisone, chlorpheniramine doses. This is the age range of the patient. In adults, we usually give about 0.5 ml in 1000. This is the concentration of adrenaline. That is 500 micrograms of adrenaline, and hydrocortisone 200 mg, and chlorpheniramine about 10 mg. These are the ampules. This comes in ampules. This is the concentration. And if the patient is about 6 to 12 years, then we give adrenaline dose of about 300 micrograms or 3 ml 1 in 1000 concentration. The 0.3 ml 1 in 1000 concentration. Hydrocortisone 100 mg and chlorpheniramine 5 mg. This is half. And 6 months, if the patient is about 6 months to 6 years, then 150 micrograms, that is 0.5 ml, 0.15 ml 1 in 1000 concentration. Hydrocortisone is about 50 mg and chlorpheniramine 2.5 mg. And if the patient is about less than 6 months, then the same 150 micrograms, that is 0.15 in 1000, and hydrocortisone 25 mg and chlorpheniramine 250 micrograms per kg body weight. Adrenaline can be repeated every 5 minutes if necessary. The best site is IM injection in anterolateral aspect of the middle third of the thigh. The common identified causes of anaphylaxis are food, example nuts, the most common cause in children, and drugs can also be the cause, or the drug allergies. Many people have antibiotic allergy or the preservative which is used in the drugs. That's why we give test dose of our antibiotics in patients. And venom, example wasp sting. Okay, now the MCQ regarding this topic. A patient loses about 1.6 liters of fresh blood from their abdominal drain. Which of the following will not decrease? 1.6 liters means it comes in hemorrhagic shock of class 3. Okay, and which of the following will not decrease? We have to see which will not decrease. I'll give you options. 1. Cardiac output. 2. Renin secretion, and firing of carotid baroreceptors and aortic baroreceptors, and blood pressure. Which of the following will not decrease? Hemorrhagic shock, BP will decrease, cardiac output will decrease, and baroreceptors, firing of baroreceptors will also decrease, but renin will increase because the juxtaglomerular cells in the kidney, uh, when BP is reduced or the kidney perfusion is reduced, it releases renin hormone which activates renin angiotensin aldosterone mechanism. Okay, thank you.